So this is Truckee, California. It's a beautiful ski town. It's where I live. After about 25 years at Cedars-Sinai, just up the street in Los Angeles, needed to recharge my batteries back in 2003 to become a ski bum and a cowboy and play the piano in a blues bar. And identified a serious disparity in healthcare, all of healthcare, but specifically cancer care. We have a catchment area of 50,000 people up there, and we're about an hour from Reno, Nevada, and 2 hours from Sacramento. We've got significant snow issues, and we had no cancer services. If ever there was an experience to go from high-end oncology to zero oncology, we experienced it. We had 100% outmigration of all of our patients. ASCO's mission is to reduce cancer health disparities. So when we were approached to, let's build a cancer program, after I said, are you kidding? We said, well, let's do a little homework and see what the landscape would allow. We had some guiding principles. In a small town, you're going to provide universal access to care, every kind of insurance, no insurance. We must take care of everybody. Figure it out later. We had to address enhanced rural fears. We had to reach out to regional thought leaders. We had to use technology to lessen our rural isolation, and we had to engage local businesses and community leaders to help pay for it. Fear is the primary human biologic emotion. Your ministers may say it's love. It's not. It's fear. And there are universal fears that everybody with cancer has, which are death, pain, and disability. But these extra fears are significantly enhanced in the rural setting. That's getting disorganized care, becoming a burden on your family and caregivers if there are any around, and the most important is getting yesterday's therapy. That's what they're very frightened of. All of us are in a perfect storm. We've got a rapidly increasing population over 65. 60% of our patients, of those people, are cancer patients. We have an exponential knowledge base growth with unpronounceable MIBs, NIBs, MABs, and ZUMABs. I mean, you guys have been listening to this for the last 3 days. We've got new guidelines and indications coming out every 3 months. And we have a legacy medical education culture. Assuming the docs can keep up with by reading journals and listening to drug reps, we're fighting this war with yesterday's thinking. So what do we have in our region? In California, we have 7 NCI-designated comprehensive cancer centers, 2 in Northern California, and in Nevada we had none. We reached out to UC Davis and helped create their UC Davis Cancer Care Network with 4 small regional cancer programs. We're the smallest of them all. Okay, stop. Vilfredo Pareto, who knows who this dude was? He was an Italian economist who studied land ownership in 1896 and identified that 80% of the land is owned by 20% of the people. It's what we call the 80-20 rule of human behavior. 80% of the work is done by 20% of your group. 80% of the patients admitted to your hospital are admitted by 20% of your medical staff. And you know that all the headaches from the coaches in Little League come from 20% of the patients, of the parents. But it's also biologic. There are about 20 anatomic cancer sites, but just 4 of them, 20%, comprise 80% of all of our patients. That's colorectal, prostate, lung, and breast cancers. So if you're going to start a new program or maintain a program anywhere, get good at those 4 diseases, really know how to manage those properly. And all the other cancers you're going to be seeing, the head and necks and the lymphomas and the brain tumors, you're going to have your infrastructure put together because you've focused on that small number of diseases that create the high number of patients. So at UC Davis, we created a virtual tumor board program focusing on those big 4. So every Monday at noon, we have colorectal tumor board. Every Tuesday, it's GU. Every Wednesday, it's lung. And every Thursday, it's breast. and it's our new doctor's dining room. It doesn't work if there's no food. We've adjusted our culture to make sure that we do this. Even if we don't have a case to present at Tumor Board, we show up.
Not everybody is going to live in a big city where there is highly specialized care, but you can bring state-of-the-art care, clinical trials therapy to patients regardless of where they are.
We're a very small hospital out here in Lake Tahoe. We're really tiny. And we're about an hour from a mid-sized city, Reno, and about 2 hours from the state capital in Sacramento. The virtual tumor board allows us to meet on a regularly scheduled basis with thought leaders at an academic center. It allows community facilities, community hospitals, to present a case at an academic place within a week of making a diagnosis.
We can look at the CT scans together, we can look at the pathology together, and reach a joint decision about the best treatment for that patient. So the advantage for our community affiliate sites is this puts them in contact directly with specialists every day of the week.
The benefit to the physician to participating in a virtual tumor board is the sense of security that he or she is doing the right thing and as close to the cutting edge as possible.
In general, we do tell our patients, I'm going to present your case to the tumor board. Patients like that because then they say, oh, you get 20 opinions for the price of one. All the different specialists get to weigh in on the problem.
These tumor boards have allowed me to feel better about what I do. And if I feel better about what I'm doing, the patients are going to get better care.
And who's the benefit? Who benefits from this? The patient.
Really want to thank the Adario Cancer Foundation for producing that. Patients come to us in Lake Tahoe from an hour and a half away, deeper into the mountains. They're really remote facilities, 4-bed hospitals. They have really difficult, it's very difficult for them to get primary care physicians, let alone any kind of specialists out there. So when they get cancer and they come to us, we decided, let's try to be creative and find a way for them to stay at home and actually keep their little local hospitals more functional, more relevant. Let the CAT scans be done at their place instead of our place. Let them not have to drive out in a snowstorm for a day 8 CBC or a 3-month follow-up visit. So we got pretty comfortable in front of cameras. Let's go ahead and create a remote follow-up office visit by telemedicine, not to a big mothership, but to a satellite of a mothership. We're the satellite. So we used APCs, which are nurse practitioners or physician's assistants. We integrated a diagnostic imaging so we could see all the images. We were not able to integrate the laboratory for, I don't want to get started on it. Anyway, we just get scanning on the lab tests. So this is a picture of myself in the lower right corner. This is what I see. We had to pixelate this thing for HIPAA. That's my nurse practitioner in South Lake Tahoe, and that's a patient, and she's in front of that screen. But this is what I see. I move that picture all the way up towards the camera on my computer. Have you ever Skyped with somebody and they're looking at and you think you're looking in their eyes, but you're looking at their eyes in the picture of the computer, so you're looking down. Well, the doctor-patient relationship is profoundly sensitive to the doctor looking in the patient's eyes. So all you got to do is shrink that picture down and move it up towards the camera, and you pretty tightly approximate the right position. And the patients can sense that. They really can sense that. Plus, you don't need to be seeing any of that other stuff. You need to be seeing CAT scan. You need to be seeing the flow sheet and the EMR so that you can actually do your job. The only complaint from our patients are, Larry, I miss the hugs. But besides that, they love it. So here's what we had. We called that the Sierra Crest Initiative. Every day, or 4 days a week, we have this solid pipeline of high-end knowledge from our virtual tumor board on 80% of our patients' diseases. A few years ago, we opened up our first remote telemedicine clinic in Portola, California. 6 months later in South Lake Tahoe, 6 months later in Quincy, and 6 months later in Loyalton. We call this a synaptic knowledge network. Now, just as your internet signal at your home degrades over distance, we're postulating that knowledge does the same. The job of an NCI-designated comprehensive cancer center is to create new knowledge. The assumption is that the medical system is designed so that that knowledge is almost instantly available to community oncologists who take care of 80% of all the patients, and we know that that's just not true. We believe that this system decreases that knowledge degradation and addresses that issue of disparities in cancer care very effectively. Okay, so what would happen if the rest of the UC Davis Cancer Care Network did the same thing? Or what would happen if all 69 NCI cancer centers around the United States did it? It could be pretty effective. So what are the results? What's in it for UC Davis? Why the hell should they care? Why should they do this? Well, increased clinical trial accrual. The Cancer Care Network, through this system, accounts for 8% of the patients enrolled in Karen's trials. Okay? It also naturally, because we're talking to these guys and we become friends and we see them every day, it's the natural place for us to send our thoracotomies, our pancreatic cancer surgeries, our bone marrow transplants. They get the high-end, complex things that need to be done. And it also helps demonstrate in a measurable way their need to maintain that comprehensive designation for the NCI that is primarily based on delivering significant services to outreach communities, and we're pretty outreach. What's in it for us? We've developed a bunch of certifications that we never dreamed of we'd have before. In 10 years, we've gone from 100% out-migration of all of our cancer patients to 52% in-migration from areas from outside of our catchment area. Why would patients do that? Because of the transparent sense of security demonstrated through the capacity to be presented on almost a daily basis to an academic center. We've gone to 3 additional medical oncologists, not counting myself because I'm really not seeing patients right now, and 1 radiation oncologist. And we've become a revenue center for our rural hospital that now supports these essential services of labor and delivery, pediatrics, and primary care. So what are the take-home points? 1, appreciate the 80-20 rule. Get really good, and this goes for all of medicine. Get good at those 20% of diagnoses that account for 80% of your patients. 2, now this is the hardest one, get smart and stay smart at lunch. Develop virtual disease-specific case-based conferences with regional thought leaders. It's the only way to keep up with the exponential knowledge-based growth. There's just no way to stay on top of this unless you connect with the people whose job it is to stay on top of a specific disease. And lastly, technology is for doctors and patients, not hospital bean counters. Use it to improve doctor-doctor relationships and doctor-patient communication. Use it to enable effective outreach to remote patients and build all of your systems to address your patients' fears. Thank you.